Good afternoon, and thank you for joining us. We'll get started momentarily. We're thrilled you could join us here today. You are at COVID-19 as a cause of acquired brain injury, lessons from current research and advanced neuroimaging. We have people joining us from all over the country today, so thank you. Well, we're going to go ahead and get started. This presentation today, Dr. Fong and Dr. Lowen have generously agreed to allow it to be recorded. So you can relax and enjoy our time today. If there's something that you want to go back and listen to, Kristen will be editing it, putting it on the United States Brain Injury Alliance YouTube channel. So please feel free to enjoy today. We are quite casual, so feel free to put a question in chat. If you have a question that you'd like asked anonymously, you can send it to Kristen or myself, and we will get it to the presenters. Please feel free to ask questions as we go. Again, I'm Carrie. I'm on the United States Brain Injury Alliance board, and this is a presentation by the Public Policy Committee for United States Brain Injury Alliance. We're thrilled to welcome Dr. Lowen and Dr. Fong from Cognitive FX. They have been doing some fantastic things over the last 2 years, assisting people recovering from COVID, and we're excited to learn from them today. So this is lessons from current research in advanced neuroimaging, COVID-19 as a cause of acquired brain injury. Let me introduce your two presenters today. Dr. J.C. Lowen is a clinical neuroscientist who received her doctorate of neuroscience at the University of Utah. Her background includes the study of basic and clinical brain injury, including the publication of research regarding mechanisms of epilepsy, pathophysiology. Dr. Lowen's focus is firstly patient care and education. She also provides literature analysis and aids in the publication of Cognitive FX's research. Her goal is to improve Cognitive FX's ability to help patients through equal interaction and communication. So we are thrilled to have her today, and she's joined by Dr. Alina Fong. Dr. Fong proudly serves on the Brain Injury Alliance of Utah board as president. She's also a board member of the United States Brain Injury Alliance and a member of the Governance and Public Policy Committee, as well as the Professional Advisory Board for Pink Concussions. She's a clinical neuropsychology major or graduate with an emphasis on neuroimaging from Brigham Young University. So we're thrilled to have her today. In addition to her continuing research activities, she is the director of Cognitive FX, the premier concussion treatment center that utilizes functional neurocognitive imaging technology. So we thank both of them, and I'll turn it over to you. Again, please put your questions in chat as we go. We're going to spend about an hour today with Cognitive FX, and then we have an investigative journalist, Michael Blocker, who will be joining us, and he has written a book on COVID long haulers and interviewed a lot of interesting people throughout the country. So we're going to be having a great conversation with him up next. But thank you, Dr. Lowen and Dr. Fong. You're up.
Thank you so much, Carrie.
All righty, I'm going to be sharing my screen. Hopefully this goes correctly, and then we'll get started with the presentation. Alrighty, so Dr. Fong and I today are going to be talking about COVID-19, specifically post-acute issues. So what we're learning is that patients that have contracted COVID of many differing varying intensities, so patients that may have been in the ICU, patients that just got a little bit of a sniffle, lost their smell of taste for a little bit, many individuals can end up with these post-acute complications. To start us off, these are just our disclosures. Again, I'm a clinical neuroscientist here at Cognitive FX, and Dr. Fong is the co-founder and owner. These are our objectives. So our goal at the end of this is for you guys to leave with an understanding of what is going on in the brain at the functional and cellular level. We want you to be able to have an idea of how people are defining these post-acute issues. In addition, we're going to talk about one of our favorite things, which is called neurovascular coupling. We're going to walk you through how it is very much involved in these post-acute symptoms. And then we're going to show you some hot off the presses patient data of long haulers that we've treated. All right. So what's really interesting, and I had no idea about this, so I did my graduate studies actually in a viral model of seizures. So where I worked in basic research, we worked with mice where we would give these mice a virus and they develop epilepsy. And then we could study those mice. I wasn't aware until actually working at Cognitive FX that these post-acute issues for patients after a virus have been known for a while. So back to the Spanish flu, where we started seeing patients developing memory issues, encephalitis lethargica, this head slowness. So this is something that has been around for a long time. With COVID, it makes it even more apparent because of the mechanisms by which the virus can infect different tissues. I like to think of COVID almost like, I don't know if any of you are hikers, when you go out and get those little burrs in your socks. I mean, just the anatomy of the virus makes it very sticky, so it can cause a lot of complications in many different tissues, which we will discuss. Okay. So, speaking to that effect, we need to consider both direct and indirect effects of the virus. So I want you to think about this tiny little particle that maybe a patient breathes in, through their mouth, or it goes in through their nose, and it can enter the body and begin to replicate. Viruses are pretty tricky because they can use us and our cells to make more of them. Now, COVID, it comes with SARS-CoV-2 infection. So I'm going to use them interchangeably. COVID-19 is technically the disease you get from the virus, but as long as you guys know that, I'm going to use them back and forth. But really interestingly, I mean, we can end up with, for example, infection in lung tissue. We can end up with infection of organs like the pancreas. You can actually end up with issues to overall immune system functioning. In addition, we see a lot of patients that develop gastrointestinal issues, diarrhea, nausea, and what we're really focused on is this upper right-hand quadrant with this brain. Many patients with COVID during the acute and sometimes chronic phases will describe brain fog, a much more clear term for encephalitis lethargica, delirium, fatigue, sleep disturbances, and changes in their mental health. So our goal is to try to figure out, okay, how much of this is brain? How much of this is just the virus causing structural damage to organs in the body? So this is going to look very complicated, but I'm going to lead you guys through the basics of this. So what we're looking at is we're zooming in on where that virus is affecting, again, the cells of the blood vessels and the neural tissue. So starting off at A, can you see my cursor?
Yes, we can.
Oh, wonderful. So I can use it like a laser pointer. Okay, so what I want to point out is starting at up here at A, production of effector molecules, so the very top of the figure. So essentially what's happening throughout your bloodstream in your body are production of antibodies and pro-inflammatory cytokines. Basically, think of those as your immune system's ammunition. It's how do we get rid of this virus? How do we flag it and destroy it? B is blood-brain barrier leakage. So the brain is actually separated from everything else. It is enclosed in its own system. For many years, we actually believed that the brain's immune system was completely separated from the body's immune system. We don't know if that's completely true still, but it is an isolated, protected system until you have a lot of production of these ammunition particles, as well as just the virus itself. So you can end up with leakage through this protective barrier that may actually allow the virus to enter. It may allow antibodies to enter that tissue where they shouldn't be going. Now, another thing that COVID-19 can cause is basically hemorrhage, where we have red blood vessels going through these cells and the blood-brain barrier and causing leakage. Oops, sorry guys. We can also have infiltration of actual immune cells, so not just the ammunition, but the cells that produce that ammunition. Now, once we get down here to the bottom half of the figure, we're talking about a lot of nervous system cells. So C here at cell infection is talking very much about the direct infection of the virus into the cells. Now, what that can lead to is a lot of cellular stress. Those cells become very unhappy. We can get degeneration of the cells, as well as alterations in the synapses. So basically the parts of the neuron that help it communicate to other neurons. We can also end up with demyelination that you sometimes see in other neurological disorders like MS, for example. Over here with these cells here aren't the neurons of the brain, but they're support cells. So we won't go into a lot of detail, but these cells help the neurons stay healthy. They help balance out how much fluid is in that environment. They keep the neurons fed. But these cells are, again, immune cells of the brain. So if there's a virus around, if there's antibodies around, they're going to pay more attention to maybe the infection or what's going on in the body rather than supporting those neurons. It's a bit of a double whammy there. Now, really interestingly, these cells are also responsible for eating up particles. So they're kind of the waste cleanup crew of the brain. And in certain situations, they can go a little overboard and actually start to eat neurons themselves. Now, interestingly enough, this huge figure, much of this is not going to show up on an MRI. The MRI doesn't have the resolution to be able to see this happening acutely, and it doesn't have the resolution often to see how this has progressed or stopped or is continuing 4 to 6 to 12 weeks after the COVID infection. So what we're going to be talking about, specifically Dr. Fong's going to be talking about, what can we measure? How can we measure how this has happened, and how does it correlate with longstanding symptoms? All right, sorry, this is a little pixelated, but overall, this is just talking about a timeline. And we're going to be talking about timelines in a couple other slides as well, but basically just understand that we have the exposure, the direct infection where you're PCR positive, so you go get tested for that virus and it goes, oh, we can pick up those little particles and it looks like you've had the infection. Then we end up with a subacute phase. So in some situations, there's been theories that certain people just don't clear the virus very quickly. Again, those immune cells and their ammunition aren't really able to target that virus, so it stays around a little bit longer. But then there's also complications where actually testing for do you have that virus is very difficult. There's a lot of false positives and negatives. So essentially what that means is that you could go get tested for the virus and then that test says, oh, you do have it, when maybe that test, there's just irregularities in all testing, whether it be blood pressure testing or even functional MRI, but it's hard to know, like, when exactly does that infection finish up? Is that dead virus particles or is that an active virus? Finally, we get to this chronic or post-COVID stage where we have fatigue, we have a lot of muscle pain and weakness, we end up with issues breathing. A lot of patients report hair loss, some pretty crazy symptoms. Right. So this was put out by Dr. Lambert and the Survivor Corps. Many of you have probably seen this or read this. What they did was they took the CDC's questions and then tried to get an idea of, okay, of all of these long haulers, which they call themselves, are there symptoms that we're maybe missing or that they're also reporting that, standard screenings may not pick up? So what you'll notice is that all the ones in the pink-orange color salmon are the CDC's kind of standard, okay, this is what they're looking for, versus the whole list is what the Survivor Corps detected. And you'll notice like inability to exercise or be active, difficulty sleeping and anxiety, a lot of symptoms going all the way down to dry eyes, tremors and shakiness, upper back pain, floaters in vision. Now, this is very complicated because during COVID-19, a lot of us were isolated. We were in our homes, we weren't going outside, we may not be eating as well. We are dealing with a lot of emotional changes, maybe if we've lost a significant partner, if we've gone to the hospital for COVID. So we do need to consider that, for example, sleep. Let's take that. It's like, okay, of course you're having trouble sleeping. You're anxious all the time. So these are interrelated symptoms, but that does not discount that patients are still experiencing these. So what we're going to be summarizing at the end of this presentation is how do we take the patient as a whole? Whether these symptoms are coming from the infection itself or whether they're comorbid with just life at the time, we need to respect that. Okay. Oh, other things that Dr. Fong and I are very aware of is that there was a lot of confusion, especially early on when we were seeing these long haulers. It's like, What doctor do you go to? Would insurance cover this? We're starting to figure this out, but we definitely have this a little bit of just do everything and see if it sticks with long COVID. Okay, so these are just some big papers. These are papers that, for example, with the Huang et al., 17,000 people were surveyed, 500. These are huge sample sizes. Unfortunately, with these huge sample sizes comes a lot of variability. So what they're looking for is how many patients will develop these post-acute issues? What type of symptoms do they experience? Were there any factors that made someone more likely to develop these post-acute issues or less likely? So the summary of all this text is everybody's finding slightly different things. Now they all tested slightly differently. Some were a phone survey, others were an actual in-person evaluation. But the summary is that in a lot of these papers, whether it be 32% or up to 70%, quite a few individuals are developing these post-acute issues of varying degrees. Interestingly enough, a lot of these issues are also intermittent. So a patient may feel that they've recovered completely, go back to work, and then crash and be like, well, my brain fog is back, I'm having heart palpitations, all of these very strange symptoms. So with this complication, we can't really trust the symptoms anymore. The symptoms aren't telling us anything. All they're telling us is that these patients are suffering and we need to do something about it, but how do we go about that? One conclusion I really like from the Morena et al. Is that it is almost impossible to take that patient's acute symptoms and say what they're going to end up with later. So a lot of things, again, could be happening behind the scenes at the cellular level we're not seeing. And then this patient that had no to very little symptoms is suddenly developing very significant post-acute issues and vice versa. All right, let's go forward. So the question is, why do you have concussion specialists talking to you about COVID? So first of all, we are a brain injury rehabilitation clinic. We run a lot of research. Our main goal is, and our main directives are very concussion-based, so mild traumatic brain injury. However, we've treated patients with hypoxic type injury, issues coming after chemotherapy. I'm trying to think of some others, viral meningitis and bacterial meningitis issues. So we do have a sampling of patients that have issues with, again, oxygenation, virus, etc. In addition, talking to these patients, I honestly would not be able to differentiate unless they told me just at the symptom level whether they were COVID or concussion. The complaints are so very similar. We've in fact had patients that had prior concussions that were like, this feels like another concussion. That's why I came to you. I know I didn't hit my head, I got the virus, but I'm just looking for anything at this point. So something we see very commonly in our patients is fatigue. It is just tiredness, slowness, not having energy draining very quickly, waking up after 12 hours of sleeping and you're still tired. So this figure off to the left is by a recent paper where they looked at patients on the left-hand side in the red where this was more severe. So you were admitted to the hospital, you were looked after there, versus the outpatient in the blue on the right-hand side where, okay, I got seen by my doctor, I do have COVID, I need to just hang out at home. Now what you're going to notice is these percents of specific symptoms. So fatigue, dyspnea, so basically breathing issues, cough, pain, insomnia, headache, and taste and smell. First thing you'll notice is these very high percentages. Those are some big numbers. Okay, I've got a 1 out of 3 chance of developing severe headache after COVID. So, me and my next 2 neighbors, which one of us is it going to be if we all get COVID? Interestingly enough, you'll also notice that there are 6 circles on the outpatient and only 5 on the hospital discharge side of things. So again, these patients that had maybe a more mild case may develop more variety of symptoms than someone in the hospital. So we don't know why this is happening. Massive research studies are being conducted to try and figure out what's going on here. But for the time being, we do know that we need to help these many, many individuals that are struggling with this issue. Okay. So I think it got blocked off, but this was from a nice report, actually from some wonderful Canadians, talking a little bit about trying to summarize what's going on, the clinical definitions, some of the research. But I liked this figure because they do go into how do we categorize these post-acute issues? You know, when is somebody in the acute phase versus when is somebody in a chronic phase? We deal a lot with this with brain injury. It's like, okay, you got a concussion. You'll be better in 2 months. You come up to 2 months, you go back to your doctor, I'm not better. 6 months, come back in 6 months. Okay, I came back after 6 months, what's going on? Well, actually some research says 2 years. You'll be cured after 2 years. Let's try some medications for your depression in the meantime. So I like that people are discussing and brainstorming about how do we categorize these phases. The National Institute for Clinical Excellence has the most specific definition. So basically from 0 to 4 weeks is the acute phase of symptoms. 4 to 12 weeks is ongoing symptomatic COVID-19. And then we have this post-COVID-19 syndrome where post 12 weeks, as long as nothing else is explaining this, this is where we're ending up with these chronic long haulers. What is slightly entertaining is that in our field of concussion, there was the term post-concussion symptoms or post-concussion syndrome, and now it's post-COVID syndrome, so they're both PCSs. The CDC has also come out with some guidelines. The World Health Organization has come out with some guidelines that are much more generic, generalized. Again, Canada has come out with some conditions as well. Something I wanted to touch on very briefly is social media. So, for example, the Survivor Corps, I believe they got started on Facebook, where their big hub is basically social media. So we do have some issues with a lot of patients maybe feeling that they are a long COVID patient, but maybe that's because they have something else undiagnosed, maybe it was a concussion that they can't figure out at that time. So again, we need very standard objective measurements to be able to go, okay, you are a long hauler, you need this type of treatment, versus no, you're not a long hauler, we actually found something else and long hauler treatment's not going to do anything for you. Okay. Finally, we're kind of finishing up on my side, and then Dr. Huang will take over, but there have been attempts to describe post-COVID syndrome. So why would we do this? Just the medical community likes to put nice little bows on, okay, you have this type of syndrome, you fit in this box versus, oh no, you fit in the other box. So some people have presented these different boxes where we have possibly this post-intensive care syndrome. There is research suggesting that, yeah, if you were in the ICU, you will innately, as a result of that experience, develop issues afterwards that may need a specific type of treatment. So in these long COVID patients that spend days or weeks in intensive care, that could absolutely be an issue and a concern. Post-viral fatigue, this goes back to that kind of historical view of this. Now, again, this is describing the syndrome based off of the symptom, not of actually what's going on. Many patients have fatigue, but maybe not always. Maybe it's only if they exercise that they have fatigue, or maybe only if they work an 8-hour day, whereas previously they wouldn't have, but on the weekends they've got more energy because they're just, lazing around the house. Permanent organ damage. This is a much easier one to describe because we do have case studies of individuals with their COVID infection developing Guillain-Barré, where it has infected neural tissue and it's severe enough you can see it on an MRI. And once those neurons are dead, they're not going to grow back. In addition, it can cause scarring in the lungs, damage to, what happened there? Damage to internal organs that's visible. So that is a very severe case that will need long-term care. And then there's long-term COVID syndrome. So basically where we don't know what's going on, everything has checked out, you're seeing your psychologist regularly, we don't know what to do with you. So our goal as a clinic was to go, okay, we have a lot of experience with brain injury, we have a lot of experience with treating it, we have experience with patients who, if you combine them all together, look like COVID. So let's do an objective scan. And again, a lot of our research uses functional MRI to image the brains of these patients in real time. So it's not a structural scan, it's a functional scan. And let's see what we see. The last thing I'm going to go over is basically what does this mean for brain injury survivors. So individuals with brain injury are already experiencing issues associated with that. So for example, an individual that's had a stroke, hemorrhage, or severe TBI may already have issues that they're trying to work through. They may already be on medications that are helping. What happens when they get the virus? Well, unfortunately, there's not a lot of good research out right now, but there are other papers and research that does suggest that these individuals with prior TBIs of any type are more at risk for developing severe consequences of COVID-19. One example is that there's good research suggesting that individuals with focus and concentration issues may not be as able to pay attention to warnings, or may, forget to put their mask on like we always do and put themselves more at risk, little things like that. Versus with our patients, we see a lot of dysregulation of the autonomic nervous system. That is where you have blood pressure issues, you develop POTS, you have heart palpitations, your GI system is already not working correctly. And to go into that, the autonomic nervous system is your fight or flight and your rest and digest. So it controls how food moves through your gastrointestinal system. It controls your heart rate and your breathing. So disruptions in that is quite significant. And so if COVID also causes autonomic issues, imagine combining those two together. I mean, that's a really nasty situation. So we're going to help as much as we can with the research side of things, help to clarify and aid these patients. But the first thing we need is knowledge. What do these patients look like? What, if we stuck them in the functional MRI, are we going to see? All right, and this is where Dr. Fong will take over.
Thank you, Dr. Lowen. And the thing that I just want to point out really clearly is COVID should be considered an acquired brain injury, and it's this understanding that really will help us, all of us here, and especially Carrie and I that are on the Public Policy Committee, try to effect change and legislation and kind of acceptance that COVID should be considered an acquired brain injury. So thank you so much, Dr. Lowen. Okay, so part 2, we're going to give a brief introduction into neurovascular coupling, and then how we measure that with fMRI, because Dr. Lowen has been talking quite a bit about neurovascular coupling, neurovascular dysregulation, and I'm just going to take that down a bit and explain what that is. Okay, so neurovascular coupling has 2 main parts, neuro or neuron, and then the vascular, which is the blood supply to the brain. And in general, we are talking about a connection and a coupling and an integration between blood supply and what the brain needs from that blood supply. Okay, so this is not a new problem. Concussion is one of those diagnoses that can be quite problematic because on structural imaging, everything looks normal, right? Just like with COVID, if you just were to do a structural MRI of their brains would look quite normal, okay? But what we're looking at is advanced neuroimaging that allows us to kind of go deeper and to see that even if the brain is looking okay, is it firing okay? So neurovascular coupling is this process by which accurate, precise, and plentiful blood flow is supplied to our neurons during activation. So our neurons do not have their own internal fuel source. They don't store energy in order to fire. They have to get that energy from blood, usually in the form of oxygen and glucose. And so what the fMRI is picking up essentially is the difference in magnetic properties between oxygenated blood and deoxygenated blood. So we can actually see which areas or how efficiently neurons are grabbing that fuel and using that fuel and firing, okay? So that's really what we're seeing with fMRI. Now, injury to these neural tissues and neural inflammation, okay, can actually uncouple or dysregulate this process. And it can happen for weeks, months, and even years. One of my favorite sayings about plasticity is neuroplasticity is real, but it goes both ways, okay? So you have a brain that's working fine, and then it's injured, and that plasticity can change to where you're less efficient. But on the other hand, plasticity can also work the other way, where with the proper therapy and the right treatment, we can get this neurovascular partnership to come back online again. Now, when there is this decoupling or this dysregulation, the regional energy supply does not equal the demand that the neurons are having, or this need that the neurons have. And this neurometabolic imbalance can lead to, sorry, there you go, can lead to chronic concussion symptoms, okay? So that's what we are trying to image, that's what we're trying to see, and that's what we're trying to treat. Okay, next slide. Just really briefly, there have been some, fMRI has come under some fire, and actually most scientific methods, can come under some fire, but fMRI kind of recently, there was a study that came out with Duke University with some criticism, which pointed out some errors that are very, very well known if you are an fMRI researcher. They're easily overcome with proper analysis, with doing the right imaging. And with us specifically, we have a normative database, biomarkers, our sensitivity and specificity rates for concussion are quite high. But why is this also important? Well, it's important to do a study correctly, but it's more important, or just as important, because regional neurovascular coupling dynamics can actually inform treatment. Because all the day long, we can diagnose and diagnose and diagnose, but what my patients are banging down my door for is treatment and help to rehabilitate this neurovascular dysregulation. Now, with that being said, and I already asked for permission, but if you're looking at the chat, as we started, there's someone of the 80 people that are here today. Someone actually said, I went to Cognitive Effects for COVID brain. It's just so nice to be in a community and to treat so many people, that we have supporters like Rachel, here, who have taken the leap of faith and come all the way out to us and gotten a scan for COVID and gotten treated. And so just thank you so much to Rachel. I'm sure she'd be happy to answer questions for those who are interested in the treatment. She said, go ahead and share it. My life's an open book. So thanks again, Rachel. Okay, all right, so how does fMRI show this dysregulation? Okay, so this patient, like Rachel, would be in the machine, a regular MRI machine, except there's a screen that she sees, and then almost like a PlayStation response pad, like a little gaming pad, okay? And they are being shown different types of cognitive tests and tasks to do while they're in the machine, okay? So here's an illustration. Here we have on the left a basic trail making task. For those of you who are familiar, this is a neuropsychological test that has a patient go from a number to a letter and a number to a letter back and forth. And you have to have the numbers in order and the letters in order. But it gets harder because then you have to search out on the page or on the screen where the next letter or number in the sequence is. So it's a multitasking kind of a test and a visual search test. So the fMRI, allows us to see which areas are activating and which areas are maybe hyperactivating or hypoactivating. So on the right-hand side, okay, this allows us to see, I know it's really hard, it's kind of hard to see because it's small, but we look at numerous different parts of the brain. Now the black lines are activations that should fall within the kind of the dark blue range here. And if you can see, JC, if you can move your cursor to that dark blue range there. Yes, so the closer that black line is to the mean or to the middle of that graph, the more healthy that brain is, the more neurovascular coupling is occurring. Now, if you look below, okay, you can see that those black lines are all over the place. You have some areas that are a little high and some that are a little low. If it's too high, we call that hyperactivation. If it's too low, that's hypoactivation. But this can clearly show that this brain is kind of pushing and pulling and overworking in some areas and not working enough in some areas. And it's like a tug of war, and this can cause a lot of symptoms. Now, on the right-hand side, the far, far right, This is a cumulative, what we call a severity index score that allows us to quickly see if a brain is healthy, which is in the green, or unhealthy, which is higher. So it goes from 0 to 5, and the higher the score, the worse the more neurovascular dysregulation there is. Okay. Next slide. JC, am I on?
Yeah,
Oh,
you're
there we go.
on. Is
Okay,
it
perfect.
being a little slow? So let me know.
Okay, no problem. Okay. So now, based off of our fMRI findings, we can now design an evidence-based treatment protocol. Okay, but we need 3 steps. The first step is to prepare, right? So a lot of our theory comes from work with our colleagues, namely Dr. John Letty and Dr. Barry Willer out in Buffalo. For those of you who are familiar, they came up with a Buffalo test that allows us to look at targeted heart rates. Okay, but what we have shown is that we need high intensity cardio, graded aerobic exercise combined with heart rate variability metrics and breathing. Okay, that helps prepare that brain that gets healthy oxygenated blood to the brain. Okay, next we need to activate. So that's when we incorporate things like neurooccupational therapy, cognitive therapy, neuromuscular therapy, vision, vestibular, etc. Okay. Then another step in this process, or the last step, and just as important, is rest. So rest, or what we call destimulation, employs techniques to help stimulate the parasympathetic, right? Because as we talked about with the autonomic nervous system, what's happening with a lot of these patients is this overstimulation of the sympathetic nervous system without that parasympathetic to calm it down. Okay, so we stimulate the parasympathetic, vagal nerve tone. We use diaphragmatic dynamics on a patient-by-patient basis. And what makes this treatment so effective is the intensity. So many have done therapy for months and years, but they don't see the improvements like they do with a very intense kind of shortened treatment week. Just to give you an idea of what someone like Rachel went through, we can go to the next slide here. We cram about 6 months of therapy into 1 week. You can see here, day 1, someone, this is just a sample, but someone could start at 9:45 a.m. and not be done till 5 o'clock. And every hour they're doing some type of a therapy based on their scan. And that's all day, every day. And their treatment culminates in a scan at the end of the week, with another fMRI at the end of the week. Okay, so outcomes. And this is very important for us to see. Now, again, this is concussion data, but as Dr. Lowen and I will discuss, the reason why we use concussion data, we didn't ask for COVID patients. We didn't ask to become COVID experts in treatment, right? It just happened because people were banging down our doors because they needed help. And a lot of them would look on our website and talk to past patients and say, these are just like my symptoms. If these symptoms are similar, can you help me? So just to present here some concussion data. So if you remember that severity index score that ranged from 0 to 5, okay, in the top left corner, and JC, Dr. Lowen, if you could move your cursor there, okay, this is what we call a radar plot. So the further away from the middle, further away from the bullseye, the worse that initial fMRI score. At the end of treatment here, we looked at about almost, if I remember correctly, about 400 patients are plotted here. At the very end of treatment, when we do that post or that second fMRI scan, you can see clearly that neurovascular coupling, that fMRI score reduced significantly. So you can see that radar plot shows the closer they are to 0, the healthier that brain as far as neurovascular coupling. And that's after 1 week. The blue below on the bottom left actually shows their subjective self-report scores. So these are patients that are filling out post-concussion symptom checklists. After a week, you can also see that those symptoms have decreased. Typically, our patients report about a 60 to 65% improvement in subjective symptoms. fMRI results are about 70 to 75% improvement. Okay, so this is just evidence that if we can improve our SIS scores, so that if we can improve the fMRI scores, we can also improve symptoms. Now, we follow up, of course, months after treatment to then ensure that stability and that they are still doing well. Okay, so knowing COVID-19's potential effects on the nervous system and vasculature, neurovascular dysregulation is a very likely culprit. Okay, so would a similar approach allow for detection and treatment of chronic COVID-19 symptoms? And if so, which ones? So that led us to look at, our methods and using them for COVID-19. So could the same methods that we're using for concussion and treatment help COVID long haulers, since the mechanism of injury seems kind of similar? Well, we were lucky enough to have the opportunity to meet, interview, and scan and treat many patients. And of course, we're only going to show a small subset of the patients that we've been able to see. But this slide kind of allows you to see the process by which even Rachel went through, okay? So they get a COVID-19 diagnosis, acute infection, their symptoms have to persist, right? We won't take them if they're less than 6 weeks with these symptoms. They come in and they do our intake interview to see if they're going to be a good fit for treatment. They then do a structural and a functional MRI. Then we apply our multimodal treatment. They then get a second fMRI, and then of course we do continued follow-up. But this is basically the process for all of our patients. Okay, on this next slide, because of how much more complicated COVID can be, we actually came up with a general checklist for COVID patients and long haulers or post-COVID symptoms that we use at our clinic intake. Again, we've probably presented this almost a dozen times in the past year, and we're adding to this list, because as our understanding of COVID changes, which, as you know, the research for COVID is changing, weekly, daily. Our methods for intake and our methods for screening have to also organically change. But this is a general checklist. We look at the pulmonary response. We, of course, look at the autonomic nervous system. Psychological, we cannot ignore the psychological side, especially, with the effects of quarantine and potential ICU stays, the PTSD that can be involved with watching a loved one or yourself going through this process and potentially seeing someone pass because of this. The neurovascular coupling aspect, hormones, and the gastrointestinal side of things. After approval, our long haulers may then undergo the fMRI and treatment, but we go through a significant checklist in order to admit them. Okay, so what we want to do is just present some case studies, some real people that have had to come through treatment. So this is a female, age 38. Again, she had symptoms in early March of 2020, and was diagnosed in March later that month. Her symptoms, notably, she reported were in the moderate to severe range. And had headache, lack of concentration. You can read those there. But then she also had the anxiety, dysautonomia, PTSD, and some visual issues. Significantly, you can see on the right-hand side here, actually, her fMRI score, her severity index score was a 2.68, which put her in this moderately impaired range as far as when we compare those patients to normal. Interestingly enough, as a take home with this patient, she stated that most of her brain and memory problems are gone, but then she started pursuing some vision therapy as per our recommendation after treatment. Okay, secondly, this is actually a patient that was another Joy treating. She actually got her infection positive test on August of last year. And it took her about 10 months to get in for treatment. She had significant breathing issues. And upon observation, it was seen that she told me, I forgot how to breathe. So we worked a lot on diaphragmatic breathing, which really helped, but she had a loss of taste and smell, quite a bit of fatigue and brain fog and headache. And what you can see on the right-hand side here was her pre-treatment fMRI was 2.32. And after treatment, she dropped to negative 0.22. And she is doing fantastically now. Okay, let's see, patient 3. This was a male, okay? Again, last year was diagnosed and it took him about 10 months to come in to our clinic. Interestingly, patient noted that receiving the vaccine post-infection actually helped him with his symptoms. Again, anecdotal, but I thought it would be kind of interesting to note. But his symptoms reduced almost 80% during his treatment period. His pre-treatment scores, you can see there was a 0.92, which wasn't as bad as the prior 2 females. And but his recovery, his post fMRI was 0.13, which was great. Next, this is another male, 37 years old. He came to us about 6 months afterward. Our lesson that we learned with him is that we need to actively screen for nutritional issues. So they are a stable weight before treatment. And you can see here, he had a lot of GI distress causing drastic weight loss and a lot of metabolic issues. Interesting thing with Michael and Dr. Lowen, you can chime in if you remember a little bit more about this patient, but you know, his scores obviously show that neurovascularly he improved, okay? But for him, it took him about 2 months after treatment for him to feel the overall improvements. And that can happen sometimes. We have patients that it can take them sometimes weeks or months after treatment before the brain starts to accommodate and assimilate the changes there. We absolutely told him that he needs to go pursue some GI and endocrine workups. As similar as concussion and COVID can be, COVID still appears to affect a lot more organ systems than concussion. So we're by no means saying that this is the end all be all, but it can at least help target a lot of the major symptoms that these patients are reporting. Okay, next patient. This is an interesting patient. So she actually lost all sense of smell and taste. But on the 4th day of treatment, she completely regained her sense of smell and taste. Again, people ask, well, does that happen for everybody? And you know, it doesn't happen for everyone, but for whatever reason, with this particular patient, we were able to kind of re-innervate that sense, and that ability. COVID has diversity in its effects. You know, there's 3 types, and we also use a lot of the PCS kind of information. But this requires kind of diverse approaches by our multimodal team to figure out what to do and how to treat them. So I'm sorry, Dr. Lowen just says she has to jump off at 1, but I want to make sure that she can chime in. But what was really interesting about this particular patient was how well and how quickly that sense of smell and taste came back for her. And you could see her results on the right-hand side. We are running short on time. So let's see. Dr. Lowen, do you think we need to go over this one real quick, or is that good for case studies?
No, I think we've shown a good sampling, males and females. So we can probably go to conclusions and talk a little bit about what does this mean, which is
let's do that.
Let's
go ahead and do that.
Okay. And while we're skipping forward, so these are the general results, but we have, interestingly enough, seen very similar to concussion, a lot more female patients than male. You might have read that or noticed that in our data. So what we're going to finally be talking about is conclusions and where the community is going from here. Interestingly enough, it's a small sampling size, but we're getting 112% functional MRI improvement. So they're, at this point, improving more than our concussion patients on that scan. Let's see. Let's skip past that and actually go here. So what Dr. Fong and I are going to talk about is basically who's treating this, how are they treating it, and it's coming from multiple angles. So this is just a discussion on primary care and what primary care can do for these patients. Your doctors sometimes know you the best. They know, okay, you were like this before COVID, and then you walk into their door 3 months after the infection and you're going, hey doc, I'm having this, this, and this, and they're going, this isn't you. This does not sound like you, versus an ER doc doesn't know you as well. One important thing here is actually this third bullet point. Objective laboratory or imaging findings should not be used as the only measure or assessment of a patient's well-being. Lack of laboratory or imaging anomalies does not invalidate the existence, severity, or importance of a patient's symptoms or conditions. We could scream this out loud when it comes to concussion or COVID. Again, a lot of these patients have this invisible injury until you use the right techniques. We will be sharing a PDF of this so you can look through these different resources and all of these definitions, but it's there for you. This is just a quick summary from the Survivor Corps has put together a bit of a list of these clinics. So not just primary care, but where patients are going to clinics like ours who have more of a multidisciplinary team. Unfortunately, a lot of systems aren't built to handle this. So for example, not everybody's under one roof, not everybody's talking to each other. So in certain situations, you may meet a case manager that then refers you out to an OT in this building, and then a COG therapist, 5 miles away in another building. And that can be a very exhausting, versus some other of these clinics are all under one roof run by a university, for example. So the U of U has a COVID clinic. There are startups all around us. So you get quite of a mixed bag. It can be hard to figure out which one's right for you, again, because these are so new. We also need to talk about the biopsychosocial. Both Dr. Fong and I have touched on this, but we need better guidelines. We need more specific testing. And for many of these patients, we need to not rule out anything, their hormones, their vision, the psychology behind it, and their brain function. So I'll let Dr. Fong take this, and then we'll have a couple minutes for questions.
Sure. So just, in conclusion, the question is always, well, where do we go from here? I kind of like how when we first started doing these presentations, it seemed really doom and gloom, it was really just sad. I mean, we're inundated with COVID numbers left and right, but as time has progressed, I feel like we as medical professionals are getting just a better handle on what's happening, and the future looks brighter, but in summary, we would just like to show that we provided evidence that COVID-19 should be considered an acquired brain injury, because COVID can make a brain look like it's actually had physical trauma, like with our concussions. The most important thing, though, that Dr. Lowen and I want to end with is that the future is bright. There is hope. Multimodal treatments are helping. Advanced neuroimaging is helping. Treatment efficacy is improving when we can use advanced neuroimaging to help us monitor that and evaluate that. And research is coming at a rapid rate. So again, thank you so much for your time and attention today. We hope we've shed some light on this for people who are here, including clinicians, survivors. We know, that you're there as well, caregivers. This information, again, might be outdated in a few months. And like I always tell Carrie, we would love the opportunity to present it again, because the research will be constantly changing. Thank you.